Welcome, everyone, to the Med Legal Green Room. I am Sam Frentzas, co-founder of the Driving Force Company. Now, today's guest, which rarely do I have to pull up 3 paragraphs worth of credits and accolades, but I really wanted to make sure I got this correct. So this wasn't a monologue that I had to memorize. So this is how proud I am and happy to have today's guest, Dr. Nelson Hendler, a nationally recognized physician, researcher, entrepreneur, and pioneer in pain medicine. So get ready, folks. Dr. Hendler is a graduate of Princeton University, earned both his MD and master's degree in neurophysiology from University of Maryland, and completed his neurosurgery fellowship at the Mayo Clinic and trained in physiatry at Johns Hopkins Hospital. He served as an assistant professor of physiology. Say this.
Neurosurgery.
Physio. Okay. So, all right. He served as an assistant professor in neurosurgery at Johns Hopkins University School of Medicine. Throughout his distinguished career, Dr. Hendler has authored 5 books, dozens of textbook chapters, and more than 75 scientific publications, and founded the Mensana Clinic, which was recognized by Business Week as one of the top pain clinics in the United States, alongside institutions such as Johns Hopkins, Mayo Clinic, and the Cleveland Clinic. Dr. Hendler has testified before the U.S. Senate on healthcare issues, lectured in more than a dozen countries, and has become one of the leading voices in diagnosis and treatments of chronic pain. Today, he continues to innovate through artificial intelligence and advanced diagnostic technologies, developing systems that have achieved a 96% correlation with diagnoses made by physicians at Johns Hopkins University. Dr. Hendler, welcome to the show. It is an absolute privilege to have you on the show.
It's very kind of you to say, Sam. Happy to be here.
Yeah, usually when I do a little research and get things ready, it's not 2 pages long. Uh, but today, I know we're going to go over our topic of commonly overlooked diagnosis in accident patients and really want to dig into your expertise here. Um, and if we're ready to go, I like to dig in right away and get to the gold and right to the steak and not the sizzle. So, why are diagnoses overlooked?
Well, there's several reasons. The most obvious one is the physicians are under pressure to keep generating the same income they did 20 years ago. And what has changed is insurance reimbursement. So, in order to keep their income levels up, they have to see more patients in less time because the reimbursement is less per visit. So, the actual average visit time is 11 minutes, during which time the doctor speaks 7 of the 11 minutes. And you can't get a history that way.
Wow.
And it's tragic. It's not that the doctors are careless. They just are under the pressure of time. In fact, there's one uh, medical insurance carrier where doctors work where they fine the doctor if he spends too much time with the patient. They say you can't practice medicine that way. And then the other thing is that they don't often recognize the sensitivity and specificity of testing, which gets to the VMA device. They don't understand what the tests actually do. And so they consequently order tests that really don't have value in terms of diagnosis. Did you know that the MRI misses disc pathology 77% of the time compared to provocative discograms?
I
Think
actually
about it.
knew that.
Yeah. It's published by Cornell, Sandu up at Cornell, and a lot of other people at other institutions have found comparable levels, and that CAT scans miss pathology 56% of the time compared to 3D CAT scans. And of course, your favorite is upright X-rays miss pathology. you know, it goes from 20 to 80% depending on who you read, compared to flexion extension X-rays. Now we're not even talking medicine here, Sam. We're talking common sense. If a patient comes in and says, "Geez, doc, I have pain in my neck," and you say, "Okay, what makes it worse?" "Oh, when I lean forward." "Okay, how about when you hold your head upright?" "Oh, no, that doesn't bother me. It's only when I lean forward." "Okay, let's see your X-rays from the other doctor." I'm not making this up. 98% of the time, the x-rays I receive are upright x-rays. Now, we're not talking medicine, we're talking common sense. Wouldn't it make sense to take a picture while a guy's leaning forward, producing the pain that he normally has, rather than in a position where it doesn't hurt him? So, I mean, that's why patients are misdiagnosed as a broad overview. Not enough time with the patient and ordering the wrong test. And
You talked about, to dive in here, about 96% correlation. So how can you improve diagnosis?
well, that's a very good point. People always say, "Well, how do you know that your test is any good?" Well, let's examine outcome studies. When you look at outcome studies, people, if you look at the medical literature, they have case reports. A doctor does this, patient gets well, he writes up the report. You got a single case report. Or he operates on 40 patients and he reports that the patient got well. 30 of the 40, 38 of the 40 patients get, there's a possible bias that may creep in on the reporting. I have over 1,000 letters from patients, doctors, and attorneys saying I couldn't find out what was wrong with me. I took your test. I got the right diagnosis. They ordered the proper testing. I got surgery. I'm back at work. I'm off drugs. I'm no longer suicidal. I have 1,000 letters like that.
Wow.
1,000. So, and that's what I call third-party validation. When the person himself or someone who's treating the patient or involved in their care says, geez, the patient took this test and he's much better. That's far more credible than what you see. I love it. Some of the things on the website. Bill S. in Oklahoma says this is a great thing. Have you ever seen those endorsements on websites? Do you believe them? Could you make them up yourself?
Maybe,
Yeah.
maybe.
But I'll send you. You want letters? I'll send you letters on stationery with the patient's email. Actually, I have a number of patients have posted on Facebook, and you say this guy is great. The test really works. So it's pretty credible when the patients themselves are documenting that the test is efficacious. And then I have, and the other thing is when other researchers prove what you said is correct. I have one Dr. Landy, who's professor of neurosurgery, University of Rome. He used my test and he published an article showing he could predict with 100% accuracy using my test. The test would predict what he would find at the time of surgery. Those are nice things.
Yeah. Those are the best things.
Yeah, the best things. And I went into medicine to help patients. I know it sounds, maudlin and all, but that's really why I went into medicine. And it's nice to see patients get well. And your thing, your VMA, makes perfect sense. I've done over 300 depositions in 75 trials in 12 different states and lectured before 10 state trial law associations. So the attorneys always say, listen, you're going to testify in front of a jury. Don't forget, there are 12 people there who weren't smart enough to get out of jury duty. So you got to make your testimony very simple. I said, well, explain to them the difference between anatomical and physiological tests, because doctors use anatomical tests, but pain is a physiological condition. So the attorney says, well, that's too philosophical. Give me an example. I said, okay, if I had an oven on the wall and I took a picture of the oven and I handed you the picture, I said, Sam, look at the picture and tell me the oven is hot. What could you tell me? Exactly.
Maybe the oven's hot. Maybe it isn't.
But look at the picture. You can't tell. But I put a thermometer in the oven and handed it to you, said 375. What could you tell me?
The oven's hot.
And that's the distinction between anatomical test and physiological test. An upright x-ray, which is a picture, the anatomical MRI, CAT scans, x-ray, they're pictures.
Yeah.
Physiological test, like your test, the VMA, is a physiological. We're doing something to the organism and measuring its response. And that is how you understand what's happening. You can't take a picture of a pain nerve. Pain nerve is thinner than your hair, you know, than a single hair. I didn't mean your hair was thinning. I meant the single hair, and you can't take a picture of it. It's below the level of detection.
Yeah.
So it's important that the doctor, A, take a careful history, what makes the pain better, what makes it worse, describe the type of pain it is. A burning pain is different than a throbbing, pounding pain, different than a sharp pain, different than a dull, aching pain. And there are three different pain nerves in the body, A beta, A delta, and C fibers, which carry the message of pain to the brain. And you have to know that certain injuries produce different types of pain. So the vessel spasm is a throbbing, pounding pain. A burning, sharp shooting pain is compression of a sensory nerve. A electric shock is compression of a sensory nerve. So once you understand what the component of pain is, the category of pain, then you can determine the origin of it. And don't forget, everybody talks about AI. The ultimate AI tool is a diagnosis.
Yeah.
What does a diagnosis do? It tells you the origin of the problem. It tells you what the problem is. It tells you what test you should order and tells you what treatment you should use. That's the purpose of a diagnosis. So without an accurate diagnosis, you're flying blind. So you talked about commonly misdiagnosis. Let's talk about something as simple as whiplash. Okay? I mean, the classic, there are 8 million new accidents a year with personal injury in the United States, about 22,700,000 auto accidents, a comparable number of workers' comp cases, and then the typical slip and fall. You know, they slipped on the
Yeah.
hanger in the changing room at Walmart and sue the Walmart for that, things like that. Yeah. All right. Now, in these cases, the whole idea is to understand what is relating, what's causing the pain. And without that diagnosis, you're not going to get the right testing. So your test, the VMA, is just perfect. It says, when I do this motion, I get this results. And this corresponds with pain. And this is so important because it really tells the physician, it gives them a guideline. It tells them what to do, it tells them where to go. So, auto accident, flexion extension x-ray, okay? Patient doesn't hit his head. Do you know that 60 to 74% of patients with cervical injury after an auto accident get traumatic brain injury? And the doctor says, what? The patient didn't hit his head. How can he have traumatic brain injury? Shaken baby syndrome. You don't have to hit your head to tear, excuse me, the brain away from the blood vessels. And that's what you're really seeing. And they never ask questions about smell, taste, memory loss, etc. The other one is the disc, of course, the disc disease, hyperextension, hyperflexion. You tear the ligaments that hold the vertebral bodies together, and you damage a disc. You don't have to herniate a disc to have a damaged disc, which produces pain. Yeah. And people don't understand that. Well, first you have to understand the construction of a disc. A disc is like a jelly donut. And think of it that way. So in the middle, in the jelly, the annulus, the nucleus pulposa is in the middle, and it herniates into the annulus. Only if the nucleus pulposa goes beyond the annulus does it show up on the MRI or CAT scan or myelogram. It's an anatomical deformity. But what doctors don't realize is that in the annulus, there are pain fibers in the rear 1/3 of the disc. So when the nucleus herniates and goes into the pain fibers, even though nothing looks abnormal on MRI, CAT scan, or X-ray, you're producing the very same pain that you would get if the disc had herniated all the way through and protruded. And that's why you have to use a provocative discogram, a physiological test, to come in, put the needle into the disc, you inject it with local anesthetic, with saline, see if it reproduces the pain, inject it with a local anesthetic agent, see if it takes away the pain. And if both those criteria are met, QED, that's the damaged disc. Now look at an example. And we talked about the MRI missing disc.
Yeah.
The other side of that is 28% of the time the MRI will identify a disc as pathological, which is not symptomatic. There's an article in New England Journal of Medicine. They looked at 92 people with back pain and found that 27% of them had herniated disc, but they were asymptomatic. Now, here's the scenario. Doctor takes the MRI, talks to the patient. Maybe he listens, maybe he doesn't, but the patient has symptoms of an L5S1 disc, but the MRI shows a herniated disc at L3, L4. The doctor doesn't do a provocative discogram. He treats the MRI, not the patient. The symptoms the patient gives are compatible with an L5S1 disc, but the MRI shows a damaged disc at L3, L4. Doctor operates on L3, L4. Patient doesn't get well because the disc wasn't symptomatic. He never gets the symptomatic disc because he never asked the right questions about the location of the pain, what made it better, what made it worse. So now you got a patient, everybody's accusing him of faking and malingering because the doctor operated on the wrong level.
Wow.
Can you imagine it? And then my favorite EMG nerve conduction velocity studies. People say I got pain in my arm, pain in my leg. So the doctor, well, let's get EMG nerve conduction velocity studies. Wait a second. If you take a mixed peripheral nerve, sciatic nerve, ulnar nerve, radial nerve, the common peroneal nerve, and you cut it cross section, 90 to 95% of that nerve are motor fibers. And motor fibers are fibers that come from the brain down the spinal cord to the muscle to tell the muscle to move. Only 5 to 10% are sensory fibers. They come from the muscle, the joint, or whatever, going up through the spinal cord to the brain, telling the brain, you got pain there, you got damage there. So now you use EMG nerve conduction velocity studies, and you put electrical current in, you measure the transit time. 90 to 95% of the electrical energy is due to motor fibers. It has nothing to do with the pain fibers, the sensory nerve fibers. So the patient's not coming in and saying, Doc, I can't move my arm. He's coming in and saying, my arm hurts. Excuse me. So you're using the wrong test.
Yeah.
And then, of course, the other one, you throw your head backwards, you tear the muscles, the anterior, medial, and posterior scaling muscles, you tear those muscles, and the blood vessels and nerves get all this scar tissue around them, and patients get thoracic outlet syndrome. Now, doctors don't even think about thoracic outlet syndrome. And it's a simple test. You hold your arms up like this for 2 minutes. If your arms go numb, it's a positive ruse maneuver. You got thoracic outlet syndrome. It's because you have scar tissue in the brachial plexus. But they do the MRI. Well, this doesn't show up. I don't know why you have pain down your arm. Well, it's because I have thoracic outlet syndrome, not because I have a disc.
Right.
And you need vascular flow studies and current perception threshold studies to measure sensory nerves, not motor nerves. And then, of course, there's TMJ, temporomandibular joint syndrome. The head goes forward, the jaw comes out, and it tears the muscles and ligaments in here. So every time the person opens their jaw, you get a pop or ring in there. And then there's Tietze syndrome, either from the seatbelt or from hitting from the airbag.
Yeah.
And you tear the ribs away from the sternum. And then, of course, the one that everybody always misses is slipping rib syndrome. It's a classic seatbelt injury. You have the seatbelt for the driver coming across the left shoulder down to the right hip. The accident occurs, the seatbelt pushes on the ribs, and the 12th and 11th rib aren't connected to the sternum. They're connected to the rib above. You dislocate the rib.
Wow.
And and the patient, I got pain over here. I don't know what it is. Your stomach X-rays look good. No. And that's a simple one. It's a hook sign. You put your finger underneath the rib, you lift up. So those are some of the typically missed diagnoses after an auto accident.
And you talk about, you said this earlier, right? Yeah, 1,000 letters, endorsements from patients, attorneys, doctors. So I'm going to go back to I want to make sure we talk about your system here. So if you could please touch upon that. So I don't want to get that lost because this is amazing information. But tell us about your system.
Well, there are three tests we offer. The first one is the pain validity test. And this one predicts with 95% accuracy who will have abnormalities on the correct medical test. And so this test has always been admitted in evidence in 9 different states, over 30 cases. Basically, it's a measure of the impact of pain in someone's life. And so it says, well, if you have trouble falling asleep at night, yes or no? Yes. What keeps you up? Pain. How many nights a week? 7. That's a different answer. Do you have trouble falling asleep at night? No. Oh, how much pain could you have? Do you wake up in the middle of the night? Yes. What wakes you up? Pain. How many nights a week? 7. That's a different answer. You wake up in the middle of the night. Yes. How many nights a week? 7. What wakes you up? Have to go to the bathroom. You know, different answers, right?
Yeah.
And then my favorite question on there, if you had 3 wishes for anything in the world, what would they be? Well, if someone is really in pain, they say, geez, doc, the only thing I want to do is get rid of my pain. That's a different answer than I want my pregnant daughter to get married. I want my son to get off narcotics, and I want health for the Pope. And these are real answers. I'm not making these up. These are
Yeah.
answers I get from patients. And then based on these answers, you can predict what you're going to find on medical testing. And so once you've clarified, and by the way, the pain validity test can be used to fight the insurance company. Insurance company says there's nothing wrong with the patient. MRI is normal, CAT scan's normal. We don't want to authorize any additional testing. You say, here's the pain validity test. 95% chance there's an abnormality on the correct medical test. He hasn't had the correct medical test yet. We need additional testing. Aha, right? So this
Yeah.
is and then of course there are always the IMEs, the independent medical examiners. But nothing wrong. He's faking. He's malingering. Not related to the accident. Pre-existing condition. You can do the whole panoply. So this test can be used to refute the IME in court. So that's the pain validity test. Once you've proven the patient has a valid complaint of pain, then you do either the diagnostic paradigm or the headache questionnaire. Diagnostic paradigm is 72 questions, 2,008 possible answers, and takes the patient anywhere from 20 to 60 minutes to complete, depending on what's wrong with them.
Yeah.
They only have pain in one arm. It's easy, goes through quickly. They have pain in the neck, both arms, low back, and both legs. It's going to take them 60 minutes to fill it out. But that's the way it should be. And then you analyze the answers using Bayesian logic as opposed to Boolean logic and artificial intelligence. And that's how you got such a high correlation with our own diagnosis from Hopkins, 96% correlation with our own Johns Hopkins Hospital doctors' diagnoses. You understand the difference between Boolean and Bayesian logic?
Oh, everybody does, right?
Sure.
Easiest thing.
Well, you explain it to him, Sam. No,
Yeah,
I'm
they taught
kidding.
that they taught that when I was studying finance in school. So
Yes, so all the quote expert systems out there use Boolean logic. It's computer language. On, off, yes, no, branching diagrams. You know, is my tire flat? Yes, no. If no, drive away. If yes, is there a cut in the sidewall? Yes, no. Oh, no cut in the sidewall. Is there a leaky valve stem? Yes, no. Is there a nail in the tread? Yes, no. So it goes through. Well, the problem with Boolean logic, it doesn't take into account that you can have multiple things wrong with the tire. And that's not how you solve problems. You come out and you use Bayesian logic. I look at the tire. Uh, my tire's flat. I've had 21 flat tires in my lifetime. 17 of them have been due to a nail in the tread. Okay. Oh, wait. 2 of them have been due to a leaky valve stem. Wait. And 1 was because I got too close to the curb and knocked the bead off the tire. So I got a 17 out of 21 chance of the nail, 2 out of 21 chance for the valve stem, 1 out of 21 chance I knocked the bead off. And that's how you get a diagnosis and a differential diagnosis And that's the use of Bayesian logic. And then we use all this, we use artificial intelligence to score the answers, etc. And that's how we have such a high uh, correlation between Johns Hopkins Hospital diagnoses.
That is fantastic. I mean, this is amazing. And now, I did not have to twist your arm or beat you on the golf course to get this call to action that we're going to do here. So, look, everyone, if you want more information, I got a special email here. You can email, and Dr. Hendler will answer your questions. If you want more information, we're not going to make you jump through hoops. So, Dr. Hendler, I appreciate you doing that. So, you're going to see the email below, and you can email Dr. Hendler, get more information, learn about this system below. Dr. Hendler, I can't thank you enough for being on here. This has been a wealth of information that you've given all our followers, all our listeners, all our clients and members. I really appreciate you being on here. I implore everyone, use the email below and dive in and get this information. It is absolutely amazing. Dr. Hendler, thank you for being on the podcast.
Thank you for having me, Sam.